Hello and good evening, everyone. So how are you all doing? I hope all of you are fine and doing great. So welcome to another live session on Eden 2. Okay, so today is the last live class for general pathology and we'll be winding off live pathology by today. And from tomorrow onwards, we'll be starting a new subject for our NEET MDS 25-26 regular batch. So please make sure that you attend all the mock tests and if you are not able to attend the live classes, then please make sure that you had attended the recorded lectures. Okay, in the app, which is available in the app. So please make sure that you complete all the works related to general pathology before moving on to the next subject. Okay. So today we are going to discuss all the remaining topics in general pathology, like the growth disorders and neoplasia, systemic pathology, and other miscellaneous topics. Okay. So, yes, we will proceed. So first question, the most important prognostic factor for a patient diagnosed with oral squamous cell carcinoma is it the size of the tumor or the depth of invasion or perineural invasion or histologic grading? Yes, this question was asked in the recent NEET MDS 2025 question paper. So I thought of including this question here. So what do you think is the most important prognostic factor, or what do you mean by the prognostic factors? Okay, so prognostic factors means factors which determine the cause of the disease or the outcome of the disease, or yes, you can call it like the factors which determine the cause or the outcome of the disease. Such factors are called as this prognostic factors. Okay, so let's have a look at what these prognostic factors for oral squamous cell carcinoma is. So for any tumor, the prognostic factor depends upon mainly the three things. One is the patient and the patient health. Okay, whether like what all comorbidities that patient have, what all other diseases the patient have, or whether the patient is healthy or not, all and the age of the patient, like that, all the these factors influence a lot for the prognosis of the disease. Okay, so first is the patient itself. The next is the surgeon. Okay, the skill and the experience of the surgeon does matter. And the last one is the tumor characteristics. So, the clinical and the histological characteristics of the tumor does matter. Okay, so these are the three main factors that influence the prognosis of the cancer. Okay, now let's have a look at the factors in elaborate. Okay, so the prognostic factors can be divided into, it can be included, the demographic factors can be included, like the general medical conditions, clinical factors, histological factors, and miscellaneous factors. All these influences the prognosis of oral squamous cell carcinoma for a patient. Okay, so demographic factors include whether the patient is old age, whether it is female, and a particular the patient belong to a particular ethnicity, and whether the patient is having any habits like drinking or smoking habits are there. All these affect the all this can make the prognosis really bad for the patient. Okay, so these are the demographic factors. Then next is the general medical conditions, like whether some comorbidities are there for the patient, like anemia or heart failure or stroke, or such comorbidities are present, then that can also make the prognosis really bad. Okay, then coming to the clinical features. In the clinical features, the all the dimensions of the tumor, the tumor thickness, tumor volume, the tumor margins, how it is, and the time of diagnosis of the squamous cell carcinoma and its anatomical location. Okay, the one that is present in the floor of the mouth has more chances of metastasis, like that. Okay, so all these can affect the prognosis. These clinical factors can also make the prognosis really bad for the patient. Okay, like that, the histological factors can also influence the patient, like the grading of the tumor. You know, like there is well differentiated, moderately differentiated, and poorly differentiated is there. Poorly differentiated has, of course, worse prognosis. And the tumor front. Okay, tumor front means how it is invading into the underlying connective tissue. Okay, whether it is in groups or whether it is like individual cells, like that. And vascular invasion, whether it is invading the blood vessels in the connective tissue, perineural invasion, whether it is invading the nerve bundle in the connective tissue, the depth of invasion, tumor thickness, tumor promoting inflammation, all these are important factors which determine the outcome of this cancer. Okay. Then the treatment part also, like the whether the surgeon is doing surgery for this patient and whether any adjuvant therapy like chemotherapy or radiation therapy is advocated for this patient, that also influences the prognosis of oral squamous cell carcinoma. Okay, so all these are important prognostic factors for determining the outcome of oral squamous cell carcinoma. But the main four ones are, one is neck metastasis, second one is depth of invasion, third one is tumor thickness, and fourth one is the PTNM staging. Okay, so these four are mainly considered. Okay, there are so many factors to be considered, but these four are really, really important. Okay, so the first one and the most important one is the neck metastasis. Okay, if there is a tumor or a proliferative growth in the floor of the mouth, and we have diagnosed it as squamous cell carcinoma, then what we can do is we can take a biopsy of the submental lymph node also to check whether the cancer has migrated into the, has metastasized into the lymph node. Okay. So that is called as the sentinel node biopsy, in which we take biopsy of the nearest lymph node to be first drained by the lymphatic system. Okay. So if there is some kind of a lesion in the floor of the mouth, then we can take a biopsy of the submental lymph nodes and check whether the tumor has metastasized into the submental lymph nodes or not. Okay, if there is it is positive for neck metastasis, then like it really shows a very bad prognosis. Okay, like 50% of the reduction in patient survival is there because of this neck metastasis alone. Okay, so neck metastasis is one of the worst prognosis that a patient can have. Okay, the next one is the depth of invasion. The next two parameters that we are going to discuss, that is the depth of invasion and the tumor thickness. Okay, that's mainly histological in nature. Okay, what we see under the microscope. Okay, mainly histological in nature, not just clinical. Okay, so depth of invasion, it there is these two terms, this depth of invasion and tumor thickness, you can like you can think like these two terms are like really same, but no, they are not same, they are really different. Depth of invasion means, for example, have a look at this image here. Okay, so this is a tumor, this pink colored one is a tumor, and this dotted line here, yes, that is the basement membrane. Okay, so this part is the epithelium and this part is the connective tissue, and between the epithelium and the connective tissue you have the basement membrane. Okay, so from the normal basement membrane till how much the tumor is getting invaded into the underlying connective tissue, that is called as the depth of invasion. Okay, so from the basement membrane till how much the tumor is getting invaded, the deepest part of the tumor. Okay, so that is called as the depth of invasion. Okay, so this is a proliferative growth. So here the depth of invasion is from this the normal basement membrane that is present, from there till how much the tumor is getting invaded into the underlying connective tissue. Yes, that determines the depth of invasion here. And here it is more like a ulcerative growth. So here also the basement membrane is here, and from the basement membrane, from the normal basement membrane, how much the tumor is getting invaded into the underlying tissue. Okay, so that determines this distance, that is called as the depth of invasion. Okay, and it plays a very crucial role in the prognosis for the patients, whether the good prognosis or bad prognosis is mainly determined by this depth of invasion also. Then next is tumor thickness. Tumor thickness means the whole thickness of the tumor. Okay, from the tip of the tumor at the upper point till the tip of the tumor in the down point. Okay, so that determines the whole thickness of the tumor. Okay, so that is called as the tumor thickness. From here, from the upper end till the lower end, how much distance is there, that determines the tumor thickness. Okay, and in this ulcerative growth also, the tumor thickness is from the upper end, the one that is at the uppermost point till the downmost point. Okay, so that determines the tumor thickness. There is difference between the depth of invasion and tumor thickness. Please note that depth of invasion will be always from the basement membrane till downwards. Okay, whether tumor thickness means it's the whole thickness of the tumor. Okay, the next is the TNM stage. Okay, TNM staging means you all know the size of the tumor and the nodal invasion, the lymph node involvement, and the metastasis. But in the recent TNM staging, if you look at it, it is mostly called as PTNM staging. Okay, why this PTNM staging? What does this P stands for? This P stands for the pathology also. Okay, so the histopathology is also involved in this TNM staging. That's why they had included this P in front of this TNM staging. Okay, so there is the recent AGCC classification of that is 7th and 8th edition. If you look at it in the T, okay, that is in the primary size of the tumor itself, they had included another parameter that is called a depth of invasion. Okay, so this is the recent staging of the TNM classification. And as you can see, along with the size of the tumor, they had included another parameter which is called as depth of invasion, because that highlights the importance of how much this depth of invasion influences the prognosis of a tumor. Okay, so that's why they had included this depth of invasion also under the primary size of the tumor. Okay, so the most important prognostic factor for the patient diagnosed with oral squamous cell carcinoma, out of these four that is given, depth of invasion is the most important one. Okay. Okay, I hope it's clear for you guys. The next question. Dysplastic cells exhibit all except. Okay, which one does it not exhibit? Okay, choose the odd one out. Okay, which one of the following it does not exhibit? Is it pleomorphism or hyperchromatic nuclei or decreased nucleocytoplasmic ratio or increased mitotic rate? Yes, what it does not exhibit? Yes, it is decreased nucleocytoplasmic ratio. The dysplasia, what do you mean by dysplasia? What do you mean by anaplasia? What do you mean by neoplasia? These terms are like closely related terms. You should know what each term means, and you should also know about the features of dysplasia. That is the cellular changes and architectural changes. These features are usually commonly asked in most of the examination. So you should know thoroughly what this cellular changes and architectural changes are. Okay, so dysplasia means disordered arrangement of cells. Okay, this figure itself is enough to like portray what dysplasia is. This is how the normal cells are arranged, and look at how the dysplastic cells are arranged above the basement membrane. Yes. So dysplasia means disordered arrangement of cells, whereas anaplasia means it is the lack of differentiation of the cell. Okay, every cell is assigned a particular function and it has particular characteristics. Okay, so if that particular cell is not doing that function and if it is not showing that particular characteristic, then we can call such type of cell as anaplastic cells. The neoplasia, as you all know, it is like a mass of tissue that is formed due to abnormal, excessive, uncoordinated, autonomous, and purposeless proliferation of tissues even after the cessation of the stimulus which provoked it. Okay, so this last part is very important because the mass of tissue continues to grow even after the cessation of the stimulus which caused it. Okay, so that kind of particular mass is called as this neoplastic mass. Now let's have a look at the two kinds of changes that are seen in dysplastic cells. So these dysplastic cells can show cellular changes and architectural changes. Cellular changes means individual cells, there will be some kind of changes, whereas tissue as a whole, if it is showing some kind of changes, then it is called as the architectural changes. So cellular changes it shows is definitely there will be change in the size and shape of the cell. Okay, that is called as the anisocytosis and cellular pleomorphism. And the nucleus also, there will be change in the nuclear size and shape. which is called as the anisonucleosis and nuclear pleomorphism, increased nucleocytoplasmic ratio. Okay, that is the where you have to point it out. There is increased nucleocytoplasmic ratio. In the options given, it was decreased nucleocytoplasmic ratio, which is wrong. What is seen is usually increased nuclear cytoplasmic ratio is there. Okay, I'll discuss about it in the next slide in detail. But let's have a look at the other cellular changes also. Like atypical mitotic figures will be there. Increased number and size of nucleoli and hyperchromasia. Okay, hyperchromasia means increased in color of this nucleus is also seen. Increased blue color of this nucleus is also seen. Okay, so these are some of the cellular changes. Now, if you look at the architectural changes, that is the tissue as a whole, if you look at it, there will be irregular epithelial stratification. What do you mean by irregular epithelial stratification? So what is the normal epithelial stratification? Normally, if you look at a keratinized epithelium, there will be basal layer at the bottom. Then there will be the stratum spinosum, stratum granulosum, then stratum corneum. Okay, so this is the normal epithelial stratification. That is, one layer is arranged above the another, one layer is arranged above the another, like that. Okay, so that is the normal epithelial stratification. But in case of this architectural change, what you will be able to see is some kind of like irregular. Okay, you see sometimes the spinal cells can be seen in the basal layer, like that. The whole stratification will be very irregular in nature. Then next is the loss of polarity of basal cells. Okay, polarity means if you draw a line through the nucleus of these basal cells, that line will be usually perpendicular to this basement membrane. Okay, so that is called as the polarity of the basal cells. So, but in case of dysplastic cells, you see, if you draw a line toward like towards the basement membrane passing through the nucleus, it will not be like extract perpendicular to the basement membrane. Okay, so that is called as the loss of polarity of basal cells. Then drop shaped retirages. Okay, usually it will be somewhat like U or shaped retirages will be seen. But in case of some dysplastic changes, there will be continuous proliferation of cells. So that will create a drop shaped retirages and increased number of mitotic figures, superficial mitotic figures, like lots of cell division is happening continuously. So that's why there will be increased number of mitotic figures also. Dyskeratosis, that is premature keratinization, can be seen in the parabasal layers, and keratin pearls within the retirages can be seen, and the loss of epithelial cell cohesion. Okay, so one important feature of the squamous cells in the stratum spinosum is one cell will be attached to the other cell with the help of interepithelial bridges. Okay, so these bridges will be lost and there will be loss of cohesion between the stratum spinosum cells also. Okay, so that are all features of this dysplasia. Okay, sometimes what they can do is they can give one feature like drop shape retirages. Is it is included? Which of the following? All of the following are architectural changes seen in dysplasia, except, like that also they can ask the question. Or all of the following are cellular changes seen in dysplasia, except. Okay, such kind of questions can also be asked in the exam. So please make sure that you are familiar with all the cellular changes and the architectural changes of the dysplasia. So this is how a normal cell, normal nuclear cytoplasmic ratio is. Okay, so this blue colored one is the nucleus and the pink colored is the cells. Okay, so normally the nuclear cytoplasmic ratio is 1:4 or 1:6. Okay, but in case of dysplastic cells, what is happening is that nuclear cytoplasmic ratio will be somewhat like 1:1. That is, the nucleus will be as big as the cell itself. Okay, because lots of proliferation and lots of cell division is happening. Okay, so the nucleus will be like really hyperchromatic and it will be increased in size also. So the nuclear cytoplasmic ratio will be mostly 1:1 in case of the dysplastic cells. Okay, so the option decreased nucleocytoplasmic ratio is the wrong one, because what is happening in dysplasia is it is increased nuclear cytoplasmic ratio. Nuclear cytoplasmic ratio can go somewhere like 1:1 ratio. Now, next question. Pap smear is used to detect dysplasia, carcinoma in situ, and invasive carcinoma or oral cavity and uterine cervix. This is based on the principle of, okay, pap smear, Papinicola smear or Papinicola staining is very important, and it is part of exfoliative cytology. Okay. So exfoliative cytology means when a patient presents with a lesion, whether it will be a white lesion or whether it is like a growth, instead of like directly going to the biopsy procedure, we can do something called as exfoliative cytology. Exfoliative cytology is one of the basic techniques, okay, to detect the dysplasia and the invasive carcinoma and all. So what we do is in basically this Papnicola staining is we take a diagnostic stick, and if it is a white lesion, we can scrap the particular lesion at the particular area of interest, and then we can take a microscopic slide and we can just smear it. Okay, smear it. The main principle behind this Papnicola stain is that there will be cells that are like not attached. Okay, so dysplasia cells, there will be loss of attachment of the cells. Like I had already mentioned in the architectural change that I had mentioned, there will be loss of cohesion between the cells. Okay, so the cells will be free, and when you scrap it, these cells will readily come in your diagnostic stick. Okay, so you can scrap it in the slide and then stain it and then look it under the microscope. Okay, so mainly it is based upon the principle of this non-cohesiveness of neoplastic cells. Okay, so this is how the cells will appear under the pap stain. It is a form of exfoliative cytology, like I had already mentioned. The cells will be scrapped from the zone of interest, and then you stain it and you smear it in the like slide, and then you stain it, and then you examine it under the microscope. It will be the normal cells will appear something like this. Okay, whereas the dysplastic cells will appear something like this. You can see, you can very well appreciate the increased nuclear cytoplasmic ratio in these cells. Okay, so this shows the cells are either dysplastic in nature. It is one of the most successful cancer screening tests ever developed, especially for the uterine cervical cancer. Okay, the pap stains are still used, very much helpful in nature also. So it can also, not just for that, it can also be used for sputum and bronchial washings, and for pleural, peritoneal, and pericardial effusions also, and for uterine gastric secretion, and for CSF also. We can check it with the help of this pap stain. Okay. Yes. Next question. The tumor which shows origin from more than one germ layer is known as, what is it called? Is it teratoma or pleomorphic tumors or choristoma or hamartoma? Tumor which shows origin from more than one germ layer is called as teratoma. Okay, so teratoma is mostly a tumor of 3 germ cell layers. Okay, both the ectoderm, endoderm, and mesoderm layers are involved in it, and mainly it is considered as a tumor of totipotent stem cells. Okay, totipotent stem cells are the stem cells which has the ability to form any type of cell in the human body. Okay, so such cells will be seen mainly in the testes and ovaries of the human beings, and there that is the most common site for this teratoma formation also. Okay, it is the testes and the ovaries. So like a ball like this can be a ball like tumor of cells can be seen like this, and it can be included, like it can include hair or nail or teeth sometimes can be seen inside the ovary like this. Okay, because it is formed from the 3 germ layers. Any structure can be seen in this tumor. Okay, so the ectodermal structures like skin, hair, nails can be seen, or teeth can be seen, and the mesodermal structures can be seen. The skeletal, like the bone, can be seen inside it, or the endodermal structures can also be seen inside it. Okay, since it is formed from any of the 3 germ cell layers, any structure can be seen inside this teratoma. So this teratoma is like mainly differentiated into 3 types. We have the benign or the mature cystic or the differentiated teratoma and the immature or the malignant teratoma. Out of the benign and the malignant one, benign one is most commonly seen. And we also have the specialized teratoma, in which like specialized cells called sometimes like thyroid cells can be seen inside the teratoma. Okay, so such specialized cells can also be seen inside the teratoma, mostly seen in children and young adults. And this kind of tumor mass that you see in the teratoma, that is called as the Rokitansky's protuberance. Okay, so remember the name, it is called as Rokitansky's protuberance. Now, let's have a look at the other options. Pleomorphic tumors. What do you mean by pleomorphic tumors? The first lesion that comes to your mind when you hear this word pleomorphic tumors is the pleomorphic adenoma. Okay, so in pleomorphic adenoma, why it is called pleomorphic adenoma? Because it is showing different morphological patterns in different parts of the tumor. Okay, so if you look at the histopathology in pleomorphic tumor, you can see at one end it is showing one kind of appearance, whereas it is in other end it is showing another kind of appearance. Okay, so such tumors are called as the pleomorphic tumors. Next, we have the choriostoma. Okay, choriostoma is mostly like a it is not actually a benign lesion, but it is most likely a heterotopia. Okay, heterotopia means normal cells in an abnormal location. Okay, so that is called as the choriostoma. For example, like this thyroid nodules like this at the tongue. Yes, that is an example of choriostoma. Normal cells, collection of normal cells at abnormal location. That is choriostoma. Then we have the hamartoma also. Hamartoma means the cells will be like there in that particular organ itself, but it will be disorganized. Okay, so benign tumor made of mature but disorganized cells of tissues indigenous to that particular location. That is called as hamartoma. Then we have blastomas also. Blastomas like neuroblastoma, nephroblastoma, hepatoblastomas are also there. They are kind of like an embryomas. It is like a group of malignant tumors arising from the embryonal tissue. Okay, that is also very common in infant and children. And those are called as the blastomas. So I hope you are clear with the terms teratoma, choriostoma, hamartoma, and blastoma. Okay, should not get confused between these terms. The next question, a simple bacterial test done to detect mutagenic chemical carcinogens is, what is it called? Yes, it is called as the Ames test. Okay, so what do you mean by Ames test? So this Ames test is a simple bacterial test that is used to detect chemical carcinogens. Okay, very simple test. Nothing like really advanced technique or nothing is used. A very simple test is used to detect this chemical carcinogens. So there are many chemicals that we use in our laboratories and all. And if you want to know whether that particular chemical is carcinogen or not, you can do this Ames test to detect it. Okay, so in Ames test, what you are primarily doing is that you are taking a strain of bacteria. Okay, which bacterial strain? It is the Salmonella typhimurium strain. Okay, so what is special about this Salmonella typhimurium strain is it is a mutant strain of Salmonella. Okay, so usually the Salmonella strain, it has the ability to produce histidine. Okay, but we are using a mutant strain of Salmonella. This mutant strain of Salmonella, it does not have the ability to produce histidine. Okay, it is not capable of producing histidine. Okay, so we are taking that strain and then we are uh, mixing it with the liver extract and then we are adding the particular chemical to be tested also. Okay, so all these three are added and then we are incubating it under like 37 degrees Celsius for like 48 to 72 hours. We are incubating it and then we are looking for the results. Okay, so at the end of this incubation period, if you are able to see like lots of bacterial colonies with the production of histidine, then that shows that this mutagen that we tested is positive for, it is a positive for carcinogen. It is a positive carcinogen. Okay. So, what does it mean is that uh, we had already used a histidine negative strain, okay, a mutant strain which does not produce histidine. But at the end result, if it is showing colonies with histidine production, then that shows that some kind of mutation has happened to this particular strain. That's why such kind of histidine positive colonies are getting formed. Okay, so that shows that this particular mutagen that we used, it is positive carcinogen. It is positive for carcinogenicity. Okay, so that's why this chemical is producing mutation in this Salmonella strain. Okay, so that is the main basis for this Ames test. Okay, if no colonies are produced with the histidine protection, then we can confirm that, okay, this chemical that we want to test, it is not a carcinogen. Okay, so this is a simple Ames test. We take the mutant Salmonella strain with no histidine production and then liver extract, and we add the this chemical that we want to test also. Incubate it after like 3 days. If you look at it, if it is producing colonies with histidine production, it's a positive reaction. The chemical that we used is positive for carcinogen. And if it is not producing the colonies with histidine, it is negative. Okay, as simple as that. Now, next question. A 6-year-old boy child reported with fever, headache, stiff neck, and seizures. His CSF was examined and it contained raised lymphocyte levels, absence of mycotic growth, and protein levels are normal, and glucose level is also normal. What is the most probable diagnosis? Is it like from the symptoms itself, we can conclude that the patient has meningitis, but what type of meningitis can it be? Is it the pyogenic bacterial meningitis or the viral meningitis or fungal meningitis or tuberculous meningitis? What can it be? Yes. So meningitis, what do you mean by meningitis? It is the inflammatory process that is involving the leptomeninges and within the subarachnoid space. If this kind infection is spreading to the underlying brain also, then it is called as meningoencephalitis. So this meningitis can be of two types. It can be infectious or non-infectious in nature. If it is infectious, it can be due to bacteria. That is called as the acute pyogenic meningitis, which is very life-threatening and has a very serious cause of disease also. Okay, so that is the bacterial meningitis is there. Then we have the aseptic or the viral meningitis is there, which is usually self-limiting nature. Then the chronic type of meningitis, which is caused due to chronic diseases like tuberculosis or because of spirochetes or the fungal types. Okay, mainly the cryptococcus or the candida can cause this meningitis also. Okay, so that is the infectious cause of this meningitis. Then we have the non-infectious causes also because of some chemical or because of the carcinoma. Okay, so that is called as the chemical meningitis and carcinomatous meningitis. Now, if you look at the infectious cause of meningitis, you can see that in normal condition, some amount of like small amount of like lymphocyte cells may be present, and glucose will be like really high, and proteins are like up to 0.4 gram per dl can be also seen. In case of bacterial meningitis, usually the predominant cell type is polymorphonuclear leukocytes. Okay, the neutrophils, they will be most common. In all the other types, you can see the lymphocytes. But if you look at it, only in viral meningitis, you will have a normal glucose level and normal protein level. Okay, in all the other types, the glucose levels will be low and the protein levels will be elevated. Okay, so in only the viral type of meningitis, both the glucose and the protein levels will be usually normal in nature. Okay, so in the question, it was said that there is like increased lymphocyte seen and the glucose and protein levels are normal. So we are going up with viral meningitis. Next question. A 40-year-old obese female patient came with discomfort in upper right quadrant of abdomen with type 2 diabetes and hyperlipidemia. No history of habits. The biopsy will show Okay, so liver diseases. Okay, so liver diseases are like really common nowadays. There is like alcoholic liver diseases are there, non-alcoholic liver diseases are there, then cirrhosis is there, hepatitis is there, and the hepatocellular carcinoma. Okay, so these are some of the liver diseases that are commonly seen. Okay, so no history of habit. It's an obese female patient and came with discomfort in the upper right quadrant, and she has both type 2 diabetes and hyperlipidemia also. Okay, so we can point towards non-alcoholic type of fatty liver disease. Okay, so this non-alcoholic type of fatty liver disease, like three types can be usually seen. Initially, steatosis can be seen, and then steatohepatitis can be seen, and it can progress to liver cirrhosis also. Okay, the case will not be as serious or as like as serious or as like risky like an alcoholic fatty liver disease, but still it can progress to the cirrhosis also. Okay, so the main risk factors, if you look at it, are type 2 diabetes and obesity and dyslipidemia and hypertension are all risk factors for this non-alcoholic type of fatty liver disease. The main symptoms, if you look at it, there will be fatigue, malaise, and there will be like discomfort in the right upper quadrant region are all normally seen. Okay, so usually it will be considered as an isolated fatty liver disease. But then it can also progress to steatohepatitis, which can, only in some patients over the years, if you don't take any treatment for it, then it can progress to cirrhosis, which again can decompensate if you take treatment. But if it is left untreated, then in our like very few patients, like over 7% of the patients, it can progress to hepatocellular carcinoma. So, okay. So if you look at them mainly this alcoholic liver disease or the non-alcoholic liver diseases, some features are like commonly seen. One is this hepatocyte ballooning like this. Yes, you can see these are the hepatocytes or the liver cells, and they are enlarged in nature like this. Okay, so this is the hepatocyte ballooning. Now next, these cells will undergo necrosis. Okay, so the initially they will show ballooning like this. Then next they will undergo necrosis. Then next is this. This specialized bodies are mainly seen in the steatohepatitis, mainly the Mallory-Dung body. Okay, so these Mallory-Dung bodies are commonly seen in both the alcoholic and the non-alcoholic liver diseases, but most prominently seen in the alcoholic types. Okay, so Mallory-Dung bodies and the hepatocyte ballooning are the usually seen the histopathological features of this steatohepatitis, whether it is alcoholic or non-alcoholic. The next question. In a 60-year-old hypertensive male patient with renal failure, renal biopsy shows onion skin appearance. The most likely diagnosis is, okay. Next is a hypertensive patient with renal failure. Okay, so kidney failure. So what can it be? Yes, it can be hyperplastic arteriosclerosis. Okay, so for that, we need to first know about what is malignant hypertension. Okay, so malignant hypertension means if constantly the blood pressure is greater than 200 by 120 mmHg, and it can result in severe acute kidney injury and the kidney failure also. Okay, so it will show something like this. Okay, so there is nephrosclerosis that is happening, and it will show the kidney like this. This is called as a flea-bitten appearance of the kidney in the malignant nephrosclerosis. Now, not just the kidneys, but the blood vessels can also get affected in this malignant hypertension. So what is happening is that in the hypertensive vascular disease, there are two things that are mainly happening. One is hyaline arteriosclerosis, and the other one is hyperplastic arteriosclerosis. In hyaline arteriosclerosis, what you see is that in the blood vessels will be like uniformly surrounded by a hyaline material. Okay, so that is called as a hyaline arteriosclerosis. Whereas in this hyperplastic arteriosclerosis, you will see typical appearance like this. Yes, this is the onion skin appearance in the hyperplastic arteriosclerosis. You see this blood vessel here? Yes, that is the hyperplastic arteriosclerosis. Onion skin appearance in hyperplastic arteriosclerosis. Okay, which is typically seen in a hypertensive patient with kidney failure. The next question, malignant pustule occurs in. So where will you see malignant pustule? Yes, it is usually seen in anthrax infection. So this anthrax infection mainly caused by the Bacillus anthracis. It is a gram-positive rod-shaped bacterium, and it can affect the skin, lungs, and the GI tract. So initially, what you will be able to see in the skin lesions are papules will be seen, and then it will get converted to vesicles, and then these vesicles will break and it will form ulcerations like this. Painless black ulcers, which is surrounded by swelling. Okay, so this is called as a malignant pustule. Okay, so such malignant pustules are commonly seen in anthrax infections only. Okay, which is caused by the Bacillus anthracis. The next question, to know long-term diabetic status, which one of the following tests is done? Okay, remember, not the word long-term diabetic status. Okay, so the test we can do is glycated hemoglobin. Okay, so what do you mean by glycated hemoglobin? The test name is actually HbA1c test. So HbA1c test, why we are doing this HbA1c test is because the glucose will be getting attached to the hemoglobin that is present in the RBCs. Okay, so such hemoglobin is called as the glycated hemoglobin. And these RBCs have a long life. Okay, they have the life of like 120 days. Okay, so we'll be able to, once you check for this HbA1c, we are checking this RBCs on. Okay, so we'll be able to detect the diabetic status for this past 120 days. Okay, since their lifespan is like 120 days, we'll be, by analyzing the RBCs, we'll be able to analyze the glucose status of this past 120 days together. Okay, so that's why this HbA1c test or the glycated hemoglobin test is the one that we use to check the diabetic status of the patient for the past 3 months. Okay. It also correlates with the retinopathy. Okay, it also correlates with the end stage diseases. Okay, end stage diabetic diseases like the retinopathy, neuropathy, nephropathy, and all those things are there. So it can correlate based upon the value that we get after analyzing this HbA1c. We can correlate with the whether we can correlate or we can predict whether the patient will go for the end stage diabetes disease also. Okay, and another main advantage is that we can also calculate the pre-diabetic state. Okay, so if the value is somewhere around like 5.6%, then we can predict that the patient in future may be prone for diabetes mellitus. Okay, he or she may get diabetes mellitus in future if he doesn't make the necessary changes. Okay, so such pre-diabetic states can also be predicted with the help of this HbA1c test. The next question, all of the following diseases are caused by prions except. Okay, so what are prions and what are the diseases that is caused by them? Okay, so prions are like very similar to bacteria or virus or fungus, and they cause like specific diseases in the central nervous system. Okay, so one of this is not a disease caused by prion. So the odd one is option B, tularemia. Okay, so the prions are like, they are like proteins. Okay, they are like aberrantly folded proteins like this, and they actually mimic like virus or bacteria, but actually they don't belong to this virus or bacteria category. They are like a modified host protein, and it lacks the nucleic acid also. It has no nucleic acid, nothing is there. But these kind of abnormally folded proteins are capable of attacking the central nervous system and has the ability to cause some kind of neurological disorders also. Okay. So what kind of diseases it can cause? It can cause diseases like Kuru and Creutzfeldt Jakob disease, and mad cow disease also. These are the three main diseases that are caused by prions. So the option B, tularemia. Tularemia is a bacterial disease that is caused by the gram-negative bacteria, Francisella tularensis, and it is kind of like a zoonotic infection, which is caused from the passed on to the humans from rabbits. Okay, so that's why it's also called as rabbit fever. And very small amounts are enough to produce the infection. So like high mortality rate is also present. So in the skin lesions, it will appear something like this. Okay, ulcerated lesions like this will be present in the skin for the tularemia patients. Next question. Multiple draining sinuses with matted lymph nodes are seen in. Okay, so these questions, like one or two questions, the ones that we had already discussed in the these questions had appeared in the NEET MDS 2024 examination. That's why I had included this under the session also. Okay, so this multiple draining sinuses with matted lymph nodes are seen in. Where will you see them? Lymph nodes, if you palpate the lymph nodes in the submandibular or submental region, you can see that they are like single and palpable and not painful in nature. Okay, that's how the normal lymph nodes appear. But if they are like clumped in nature, okay, so that is usually seen in some kind of infections. Okay, so what kind of infection you will see them? Mainly the tuberculosis infection. Okay, so when the term draining sinuses are used, you can get confused with the option B, actinomycosis also, because actinomycosis also produce draining sinuses with sulfur granules. But matted lymph nodes with multiple draining sinuses are a characteristic feature of tuberculosis only. Okay, so tuberculosis, it is caused by the bacteria, Mycobacteria tuberculosis, or other species are also there, like the bovis and the atypical mycobacteria are also there. This tuberculosis, it is a communicable chronic granulomatous disease. Okay, so usually it affects the pulmonary, it affects the lungs and cause the pulmonary infection. But sometimes it can also affect the lymph nodes, mainly the posterior cervical and the supraclavicular lymph nodes, and it can cause painless swelling of the lymph nodes. Now, when it causes the painless swelling of the lymph nodes, it can create a matted, non-tender mass like this. Okay, it will not be painful, but if you palpate the lymph nodes, it will be very clumped in nature, and you can palpate and see whether it is matted or not. Okay, it will be very evident. Okay, so such matted non-tender mass will be there, and by time a fistulous tract of the draining caseous material can also be seen oozing out from those lymph nodes. Okay, so such a case is called as tuberculous lymphadenitis, or it is also called as scrofula. Okay, so the scrofula is also called as skin sevil, but that term is not nowadays used. So it is called as scrofula or tuberculous lymphadenitis. That is the most appropriate term. Okay, so this lymph nodes, matted lymph nodes, with over time, fistulous tract can be seen draining the caseous material from these lymph nodes. Okay, so such a case is called as the scrofula. The next question, the Koplik spots are seen in. Where will you see the Koplik spots? Is it bacterial infection or fungal infection or malignancy or viral infection? Where will you see them? Yes, this is an easy question. It is a viral infection. Okay, mainly these Koplik spots are seen in measles or rubella. Okay, if they had specifically asked the infection, then that can be confusing. But they had just like broadly asked whether it is a bacterial, viral, or fungal infection. This question also appeared in the NEET MDS 2024 examination, and it was an easy question. Yes, the measles or rubella is the most common infection that is showing this Koplik spots. It's caused due to the morbillivirus of the Paramyxoviridae family, and usually children of 1 to 5 years age are affected. And there are 3 stages for this measles, which will be lasting for 3 days. Okay, so that's why it's also called as 9-day measles. Okay, so 3 stages lasting for 3 days. That's why it's also called as 9-day measles. So if you look at the first stage is characterized by 3 C's. Okay, you can remember the 3 C's. There will be cough, coryza, and conjunctivitis. Along with fever can also be there. Mainly, the three C's will be seen in the first stage: cough, coryza, and conjunctivitis. And in the first stage only, you will be seeing this blue-white macules surrounded by reddish area in the buccal mucosa, which is called as the Koplik spots. These Koplik spots, they resemble the grain of salt. Just like salt is sprinkled over the buccal mucosa, yes, that's how it appears clinically. Okay, so these are the Koplik spots. And in the second stage, there will be continuation of fever. And in the second stage only, you will be start seeing the rashes. The maculopapular and the erythematous rashes will be seen. Okay. In the third stage, the fever will end and the rashes will fade, and there will be brown pigmentation and the desquamation of the skin in the areas of the rash. Okay. Brown pigmentation and desquamation of the skin can be seen. Okay. So these are the three stages of the measles, which is also called as 9-day measles. First stage, cough, coryza, and conjunctivitis, and Koplik spots. Second stage, rash will be there. Third stage, the fever end and the rash fade, and the brown pigmentation and desquamation of skin is usually seen. The next question, the type of chromosomal anomaly shown in the given image is. Okay, so this is an image-based question. So what kind of anomaly is usually seen here? This question also came in the NEET MDS 2024 question paper. So the kind of chromosomal anomaly that you see here is reciprocal translocation only. As you can see here, this part of the chromosome is getting cut and it is like there is exchange between the chromosomal areas, but no loss is there. Okay, so this is the reciprocal translocation. Let's learn about the chromosomal abnormalities in detail. So chromosome are like special structures that you see inside the nucleus of a cell, which carry the genetic material. And if you look at the parts of the chromosome, at the center of this chromosome is called as the centromere, and it has finger-like projections like this. So this finger-like projections may not be like equal in length. It depends upon the position of the centromere. Okay, if the centromere will be usually a little bit towards the end of this finger-like projections. Okay, so these finger-like projections, they are called as the chromatids, and it will create like two unequal arms. Okay, or four unequal arms. Two arms will be small in nature, and the other two arms will be longer in nature. Okay, so these smaller arms, they are called as the P arm or the petite arm, and the longer arms, they are called as the Q arm. Okay, so there we have the P arm and the Q arm. Now, when the cell division is happening inside the cells, there can be some kind of abnormalities happening in the chromosomes. Okay, so sometimes it can be numerical abnormalities. We have like both the autosomes and the sex chromosomes are there. Okay, there are 22 pairs of autochromes and 2 pairs of sex chromosomes are there. Okay, so totally 46 pairs of chromosomes are there. Okay, so if there is some kind of changes that is happening in the number, like in Down syndrome or Klinefelter syndrome or Turner syndrome, that will result in numerical abnormalities. That is a result of numerical abnormalities. Then we have the structural abnormalities like balanced structural alterations and unbalanced structural alterations. In these structural abnormalities only, the translocation, deletion, inversion, and ring chromosome and isochromosomes all come. Okay, so let's have a look at what this deletion is. Deletion, just like the word suggests, one part of the chromosome is deleted from the after the cell division. Okay, so that will create a deletion chromosome like this. Next is isochromosome. Isochromosome, usually the cell division happens in a vertical manner. Okay, in a vertical manner. So one P arm and one Q arm will be there, and another P arm and another Q arm will be there. But if it is happening in a horizontal manner, then it will create two like chromatids with two P arms and two Q arms alone. Okay, so that will create something called as isochromosomes. And if you look at ring chromosomes, what is happening in ring chromosome is that the end portion of the chromosome are getting cut, and this is forming a ring-like structure like this. Okay, with the deletion of the end fragments. Okay, Sorry, excuse me. Yes, so that is about the ring chromosome. And next we have inversions. Okay. Paracentric and pericentric inversion is also there. So before that, let's have a look at the translocation. What are the two types of translocation? One is the reciprocal translocation and other one is the Robertsonian translocation. So in reciprocal translocation, just like that mentioned, a part of the chromosome is translocated with another chromosome. Okay. So this part is coming here and this part is going there. Okay. There is no gain or loss of genetic information is happening. Okay. There is no gain or loss of genetic information that is happening. Okay. So that is the reciprocal translocation. But in case of Robertsonian translocation, which is most commonly seen in acrocentric chromosomes. In acrocentric chromosomes means the centromere will be somewhat towards the end of the chromatic. Okay, so it will have a very short arm and it will have a very long arm like this. Okay, so such kind of chromosomes, they mainly show this Robertsonian type of translocation. In this Robertsonian type of translocation, what is happening is that there is breakage and there is joining of the long segments. Okay, the long segments are getting joined and the short segments are getting lost. Okay, so there is loss of information that is happening in the Robertsonian translocation, whereas in the reciprocal translocation, there is no loss of information. So in the given image that is in the question, you can see that there is only translocation between this part and this part of the chromosome. There is no fragment or there is no loss of information that is happening. So the most appropriate one will be reciprocal translocation. Now it is also mentioned as option B and C, the paracentric inversion and pericentric inversion. So let's see what this paracentric and pericentric inversion is. Okay. So if the inversion, just like that, what is happening is that a portion of the or a fragment of the chromosome is getting inverted. Okay. It is getting inverted and it is creating some kind of a abnormality. So if the inversion is not involving the centromere, then it is called as paracentric inversion. Okay. If the inversion is happening involving the centromere, then it is called as pericentric inversion. Okay. So these are the two kind of inversions. One is paracentric inversions not involving the centromere, and the other one is the pericentric inversion that is involving the centromere also. Okay. Now, next question. A child patient showed clinical features of mental retardation, flat facial profile, oblique palpebral fissures, epicanthic folds, and simian crease. What is the diagnosis? This is also a question that was asked in the NEET MDS 2024 examination. Okay. So, the key word here is the simian crease. Okay. So, the simian crease is most commonly seen in Down syndrome, which shows trisomy 21. Okay, so this is the karyotyping of the Down syndrome. As you can see in the Down syndrome, in the 21st chromosome, there will be an extra chromosome that will be present. So that is called as this trisomy 21. And typical features like the mental retardation, abundant neck skin, epicanthic fold, flat facial profile, umbilical hernia, and the gap between first and second toe are all common features of a child suffering from Down syndrome. It is one of the most common genetic disease that can occur in a child and mainly caused due to advanced maternal age and or because of some uterine or placental abnormalities or because of some chromosomal aberrations. So the typical like the main point here to note is this simian crease. Okay, so the simian crease is a typical feature of this Down syndrome. As you can see in our hands, there are like two transverse creases that are present in our hand. But in case of a child with Down syndrome, only one transverse crease like this will be present. Okay, so that's why it is called as a simian crease. But now this term simian crease is not usually used. It is the single transverse crease. Okay, so that's only used. Okay, this term, particular term, simian crease is not used. Okay, so that is the main point to identify the trisomy 21 and other general features like the brachycephalic skull, oblique palpebral fissures, candy eyelashes, short and broad neck, and the mental retardation, cardiac diseases can all be seen. There are typical oral manifestations for this Down syndrome patients also, like the small drooping mouth, protrusive fissured tongue, dry and fissured lips, bifidula, low caries incidence, and higher caries of periodontitis are all features of this patients suffering from Down syndrome. The next question, the offsprings of an autosomal recessive mother and a normal father will be. Okay, so this question was asked in the recent NEET MDS 2025 question paper. Okay, so an autosomal recessive mother is there and a normal father is there. Okay, so their offsprings will show what kind of inheritance pattern. Okay, so is it there'll be like 25% carriers or 50% unaffected offsprings, or all the offsprings will be unaffected, or all the offsprings will be carriers? Yes, the answer is 50% unaffected offsprings. Okay, I'll show you how. So this inheritance patterns can be broadly of two types. We have the autosomal inheritance pattern and the sex-linked inheritance patterns. Okay, so before that, you should know the uh, about the autosomes and the sex chromosomes. Okay, so in our cells, take any cell in our human body, if you look at the chromosome number, there will be like 23 pairs of chromosomes. Okay, 23 pairs of chromosomes or 46 chromosomes will be there. Now, out of these 23 pairs, 22 pairs will be autosomes. Okay, and that is the 44 will be autosomes and one pair will be sex chromosomes. Okay, so that's how the chromosomal number is there. Now, if any kind of like mutation is happening in this autosomes, okay, any kind of change is happening in this autosome, then that will be inherited to the next generation in the form of this autosomal inheritance pattern. Okay, but if some kind of change is happening in the sex chromosome, then that will be can be inherited into the next generation in the form of this sex-linked inheritance pattern. Okay, so again, this autosomal inheritance pattern and sex-linked inheritance pattern is divided into two. We have the dominant pattern and the recessive pattern. And for the sex-linked or the X-linked pattern also, there is dominant pattern and the recessive pattern. Okay, so here we'll be mainly discussing about this autosomal dominant and the recessive patterns alone. Okay, because the questions asked is related to the autosomal dominant and recessive pattern. We'll be mainly focusing on this autosomal dominant and recessive pattern alone. Okay, sex-linked is much more complicated and I don't want to confuse you today discussing that also. Okay, so we'll discuss that on the some other day. But today we'll be mainly focused on this autosomal dominant and recessive pattern. So what you mean by this dominant inheritance pattern or recessive inheritance pattern, I will tell you. Dominant inheritance pattern means if a single copy of the mutated gene is present in one parent, okay, suppose if the father is having an autosomal dominant mutated gene, okay, that is enough to cause mutation in the progeny. Okay, so one single copy of mutated gene in one parent is enough to cause like defect or some kind of a disease in the progeny. Okay, so that shows the dominant pattern. Okay, so in dominant pattern, usually there is like 50% chance for passing it to the next generation. Okay, it is a dominant gene, so it will show its dominance in the next generation also. Whereas in recessive pattern, what is there is two copies of the mutated genes are needed to produce some kind of disorder in the next generation. Okay, so two affected parents are needed. Okay, if the father is also a carrier, if the mother is also a carrier, then there are like 25% chance of that the child will be affected with that particular disorder. Okay, so that is called as the recessive pattern. In the recessive pattern only, there will be presence of carriers. Okay, it will not be fully expressed, but that mutated gene is present inside the body of a individual, but it will not be fully present. Okay, the carrier may not be showing some kind of a symptom of the disease. Okay, so that is the carrier. So that is what you mean by the carrier. Okay, dominant pattern, there will be no carriers because that mutated gene is present, it will be expressed. But in the recessive pattern only, there will be the presence of these carriers will be there. Okay, because some kind of mutated gene will be present inside the body, but may not express it. Okay, so that's why it's called as a recessive gene. Okay, but there is, if mother and father both have this carrier gene and their offsprings are forming, at least like 25% will be present in the next generation. Okay, in the next generation, at least if they have 4 children, at least one of them will be definitely affected with the disorder. Okay, so I hope I had made myself clear. In case of any doubts, you can ask now. So let's have a look at this autosomal dominant inheritance pattern. The one thing that you have to remember while learning this autosomal inheritance pattern is that you don't have to like be much concerned about the gender of the parent or gender of the children. Okay, because that will be playing a major role in the X-linked disorders. Here in the autosomal inheritance pattern, you don't have to like be so much concerned about the gender of the parents or the gender of the children. Okay, so in the autosomal dominant inheritance, if there is one affected parent, then there is like 50% progeny will be definitely affected. Okay, just one affected parent is there, but definitely out of the 4 children, if they are having, 50% will be definitely affected and 50% will be non-affected. Okay, so this is the autosomal dominant pattern of inheritance. And another characteristic feature is that this dominant inheritance pattern, it does not skip generations. Okay, if the father or mother is having the disease, definitely some kind of disorder will be present in the progeny also, in the next generation also. It will not skip generations. Okay, so that's a characteristic feature of this autosomal dominant pattern of inheritance. Almost all the diseases that we study in pathology, like the Marfan syndrome, Ehlers-Danlos syndrome, epidermolysis bullosa, Gardner syndrome, almost amelogenesis imperfecta, dendrogenesis imperfecta, almost all the diseases are this autosomal dominant pattern of inheritance only. Okay, so 3 things that you have to remember about this autosomal dominant mode of inheritance. One affected parent is enough to cause some kind of disorder in the next generation. 50% progeny will be affected and 50% progeny will be unaffected in this autosomal dominant pattern of inheritance. Okay, no need to get concerned about the gender because this is autosomal mode of transferring that is happening. In the X-link only, you have to be careful about the gender also. And another main thing is that it does not skip generations. Now, next is autosomal recessive inheritance pattern. Okay, so first in the autosomal recessive inheritance patterns, there are 2 conditions. That is, 2 parents are carriers and one is a carrier and one is a normal parent. Okay, we will discuss them both. So the first case is this, 2 are carriers. When 2 are carriers, if mother and the father are carriers, then 50% progeny will be carriers like this. Okay, 50% progeny will be carriers. That is, the mutated gene is there in the children also, but no clinical symptoms will be there. Okay, no clinical features or no clinical signs and symptoms will be there, but they are, that particular mutated gene is inside their body. Okay, so that is the carrier children. Okay, so the 50% of them will be carriers and 25% will be unaffected and 25% will be affected. Okay, so this is the normal autosomal recessive pattern of inheritance if both the parents are carriers. Okay, if both the parents are carriers, then this is what is happening. 50% carriers, 25% are unaffected and 25% affected. Okay, here also, since it is a autosomal inheritance pattern, no need to be concerned about the gender, and it usually skips generation. That is, in one generation, it will be seen. In the other generation, no clinical signs and symptoms can be seen. Okay, so this recessive pattern, it can skip generations. Okay, so that's the main difference between the dominant and the recessive pattern of inheritance. The diseases like cystic fibrosis, phenylketonuria, albinism, Tay-Sachs disease, sickle cell anemia, thalassemia major are all examples of this autosomal recessive pattern of inheritance. Now, this is two parents are carriers. Okay. Now, next have a look at the one that is mentioned in the question. That is, one is a carrier and one is completely unaffected. Okay. So, what can be the case? If one parent is a carrier and the other one is completely unaffected, then what can happen is 50% of the children will be unaffected. Okay. 50% will be unaffected and 50% will be carrier. Okay. So, this is the general pattern of autosomal recessive type of inheritance if one parent is carrier and the other one is unaffected or a normal parent. Okay, so if one parent is unaffected and one parent is carrier, then usually 50% unaffected children and 50% carrier children can be there. Okay, none of them will be completely affected. Only carriers and unaffected children will be there. Okay, the ones that is showing the typical signs and symptoms of a disease will not be there. Affected children will not be there. Okay, so in the options, 25% carriers, no, it is 50% carrier will be seen. 50% unaffected offsprings will be seen. Yes, that's right. All the offsprings will be affected. No. All the offsprings will be carriers. No, that also. No. Okay, so only 50% unaffected children are usually seen for autosomal recessive inheritance pattern with one unaffected parent and one carrier parent. Okay, so I hope you got the answer. This question is very important because they can ask questions in genetics related to this pedagogy and the this thing and all, pedigree chart and all. So it is very important that you know about the inheritance pattern. Then there is the X-linked inheritance pattern also, which is much more complicated, which we'll definitely discuss on some other day, because I don't want to confuse you by discussing both this autosomal pattern or the dominance pattern and recessive pattern of the autosomal pattern and with the X-linked pattern also. Okay, so first learn about this thoroughly, about this autosomal dominant and recessive inheritance pattern thoroughly, and then on some other day we will discuss the X-linked or the sex-linked inheritance pattern also. That is much more complicated. So yes, that's all for today, I think. If you have any doubts regarding the topics that we had discussed here, you can put it under the video here. We will definitely respond to it, your queries. And with this class, we'll be winding off general pathology. And we'll be moving on to the next subject from tomorrow onwards. So all the best for your preparations. Do well and keep studying, keep learning, and keep revising also, and keep doing MCQs in the app also. So all the best for your preparations. Do well. Thank you. Thank you so much for attending the session. And we'll see you on for another live session. Okay. So bye. Good night.